What's up, guys? Today we're going to go over MS. So this is one that's definitely going to show up on the boards one way or another because it's common that we'll see a patient like this in many different settings: outpatient, inpatient, acute care, even maybe even cardiac rehab, something like that. Definitely neuro rehab. And this is an easy one that they can quiz you on. If you don't know your stuff, you can easily get tripped up. So let's get into it. So anatomy, and this is super important, it's a demyelination, so meaning that our myelin sheaths are getting messed up in the central nervous system. So a lot of times we'll see peripheral neuropathies. This comes from the brain and the spinal cord. So just understanding that the myelin sheaths are not working. And there's a cute little picture down here that kind of shows how it doesn't work. So remember our myelin sheaths, this is our myelin sheath here. And these little spaces are the nodes of Ranvier or whatever they're called. I might have said that wrong. But in order for impulses to propagate down the neuron, it's hopping along, wee, like this little dude is. Look how happy he is, whoosh. So he can get down the neuron just right. So I like to think that the nerve has manageable jumps that I can get through because our myelin is working. Now, if we look at the top picture up here, we see that there's no myelin sheath. So this guy's like, man, it's going to take me a while. I got to really back up and then jump across. So it's going to take me a while and stuff like that because there's no little bump here. That little myelin sheath, it's gone. It's not there. So that means that the nerve velocity and the nerve conduction is going to be super slow now. Well, here, this would be normal. So as we see a slowing, we're going to see lots of problems with the ability for the person to control their muscles, for the person to be able to complete their activities, daily living, transfers, and all that stuff. That's going to start being problematic. Now, noting that this is an upper motor neuron disorder due to the fact that it's affecting the central nervous system because it's coming from the higher ups. So we're going to see problems with that. We'll see spasticity a lot of times, especially with our patients. So you might see it present unilaterally. There's a lot of different things with MS, but you're going to see mainly the biggest thing is it's going to slow the rate of impulses in transmission, which means it's going to be more difficult for the patient to communicate with their muscles. So they might tell their arm to lift up, but it's going to be super slow. They're going to have lots of problems controlling and motor neuron recruitment and stuff like that. And it's just going to be a problem. And unlike our other neuro disorders, such as like ALS or Guillain-Barré, this is random. So there's no real pattern. So remember with Guillain-Barré, so I'm just going to write this here, Guillain-Barré, we got, we're going to progress distal to proximal bilaterally. And with ALS, we progress distal to proximal unilaterally. But with MS, random. It's all over the place. You see a random progression of deterioration and loss of motor control. So that's kind of what's going on with the anatomy with MS. So etiology, our cause is mostly unknown, but we're thinking a lot of times that it's caused due to a viral infection. So that's the same thing we'd see with Guillain-Barré. We're thinking it's some sort of viral infection causing some sort of autoimmune reaction, which is essentially what MS ends up being, just the body's attacking its own myelin sheaths in the central nervous system, and then it's not working. So that's not good. They're also thinking that there's a genetic component. So a lot of times when families have somebody in their family who is diagnosed with MS, they'll get a lot of genetic testing to see if there's like a gene that's associated with it or a gene that could be expressed that causes MS. They're still doing a lot of research on it, but they're noting that there might be a genetic component. So understanding family and caregiver education is going to be super important, similarly to how Huntington's disease is a inherited genetic disorder. So kind of being careful with that. And then for some reason, they're noticing that in more temperate climates, there's more people with MS. That's just something that they noticed. That was an environmental factor, such as environmental factors with somebody getting lung cancer is due to them smoking, somebody getting COPD is due to them smoking. That would be an environmental factor. For some reason in temperate climates, we're seeing this more. More common in Caucasian individuals and more common in women between the ages of 20 to 35. So we got a white chick who's young. That's the most common that we're going to be seeing. And this is for all different types of MS. I mean, there's different types of people that could end up getting it later in life and whatnot, but we start to see the onset in younger women who are white most of the time. And that's the kind of thing, if the boards is going to ask you a question, which one of these individuals would be most likely to present with MS? Like it'd be like age range or like ethnicity, race, whatever, and they're going to just put that in there and be like, okay, which one of these? They'll do that for stuff like carpal tunnel. They'll do that for adhesive capsulitis. So just kind of being aware of what kind of individual will be most likely to present with this. It's a young white chick. So I hope that that helps you with remembering that. And so let's get into what it does it look like. So we're going to see a lot of different problems with MS. Understand that, remember, this is an upper motor neuron disorder. So we're starting to see like spasticity, hyperreflexiveness, problems with like moving the muscles still work half the time, but they're being all weird. So you'll see visual problems. And the biggest one you're going to see is this thing called optic neuritis. So if you're seeing optic neuritis, automatically associate optic neuritis with multiple sclerosis. So this is essentially what it looks like. It looks like, so this is normal. This is with optic neuritis. It's like super fuzzy, super blurry. And this is also going to impact treatment. If the patient can't really see what they're doing, they're going to have some problems with that. So making sure that we're, watching what the patient's doing, making sure they can see. Maybe they need to be treated also by an ophthalmologist to address their eye issues, stuff like that. So just being careful with that with the patient. Other safety things is that they're going to be ataxic and they're going to have a lot of gait deviations. That means this individual is probably going to be using a rolling walker or even needing to be in a wheelchair or parallel bars or something like that due to their ataxia. So that means that we're going to work on gait pattern and stuff like that. Just walking in general. This patient is a fall risk, so we got to stay close to it, got to stay in contact at the very minimal contact guard with a gait belt with this patient due to their nature of their gait. So that means we're also going to be working on balance problems. They might end up with vestibular disorders just due to the fact that they're having problems with the nerves themselves, the demyelination and stuff like that, that could involve some vertigo and stuff like that. They're seeing that, but mostly we're going to see balance problems. Makes sense because they're ataxic and stuff like that. They can't balance. Again, with this patient is a fall risk. I'm sure a lot of you guys, when you open up a note for the first time, see, is this patient a fall risk or not? This patient is a fall risk. So we got to make sure we're staying close to them. The biggest thing with them is they're going to exhibit a lot of fatigue. So that means when we see fatigue, that means we got to do our energy conservation techniques. Just abbreviating that there, because their muscles aren't working the way that they're supposed to. It takes a lot of energy for them to move their muscles. They're going to get tired really quickly. And remember, they get tired, they could have an exacerbation. We don't want that. Exacerbations mean that the disease is progressing. The disease is getting worse. Also, due to the nature of the demyelination, you're going to see some sensory changes. So you'll see some peripheral neuropathies. That's the main thing that you're going to see with that. And then just like desensitization in general, they're going to just not be able to feel anything. So that will kind of implicate their ability to walk. So if they can't feel their feet, that's going to be a problem. So just being careful with that. So exacerbations are going to make these symptoms much worse. And here are some major things that can cause exacerbations. The big one that the board likes to talk about is heat. Now, I know that there's stuff to support that aquatic therapy would help with people with MS. However, most pools are heated. So if the pool is heated, we don't want that. Now, could we suggest a patient walking in a pool like outside where it's like a nice cool pool or something like that, working on walking? Yeah, of course. But those heated pools that we usually have in most treatment centers, we want to be careful with that. And generally for the boards, unless stated otherwise, the pool is going to be heated. So I would stay away from that in general, because heat is a big exacerbator of MS. And a lot of these patients, if they're living in their home, they're gonna have their home like super cold, like 60 degrees or something like that, because they can't handle the heat. So they're probably not going to be electing to live in Florida or something like that. They're going to be wanting to stay in more colder climates. So that's kind of what's going on with this patient. Stress also, so be careful with our patients, especially because a lot of our patients are younger. They might have been diagnosed with MS. They might be in college. They might be working a job. Understand that the stress can exacerbate their symptoms. We don't want exacerbations. Again, the boards is a safety test. The boards does not want you to exacerbate your patient's MS. You don't want to exacerbate it either. They don't want to exacerbate it. Just avoid it. So stress is a big one. And then any sort of additional infections, because we saw that the infection causes MS. So obviously it can make it worse. So we definitely don't want our patients getting any sort of infections, any sort of trauma. So patients that might end up in sort of like a car accident or having like emotional trauma from dealing with a spouse that might not be treating them the way they should be, another individual in their household not treating them the way that they should be, or just a lot of trauma happening in general with their family members, or just with how they're just being like they've been diagnosed with the terminal disease, essentially. That's pretty traumatic for them as well. So understanding that we got to be sensitive to our patients, because this population is at a very high risk for divorce, domestic abuse, and then also for suicide. So being very careful with our patients, making sure that this person's also getting treated by some sort of psychologist or somebody that can help them mentally with what's going on, because we want to make sure our patients are okay, because we treat the whole person, not just their condition. Another thing that can cause this is pregnancy. So that's why they are very hesitant to have these individuals, especially the female individuals, get pregnant, because this will cause exacerbations of their symptoms, and we really don't want that to happen. So they really try to like tell them, hey, it's probably not the best idea for you to have children. So understand, if you do have a patient who is pregnant with MS, to be very, very, very careful, because first of all, I feel like pregnancy just in general will make people very upset and angry and stressful and stuff like that. And then throwing MS on top of it just makes it so much worse. Then here's the big thing down here: overexertion. Do not overexert this patient. That's why we go back to our energy conservation techniques. So yep, that is why, because if we overwork this patient, they could be down for days. So like our normal patients that come to the clinic that we got to work on strengthening and stuff like that, they can be sore for a couple of days, but they'll survive. Overexerting an MS patient could like really screw them up, really deteriorate them. They could go from walking one day to, if they overexert themselves, they have to be in a wheelchair for the next month. Like, you really got to be careful with this patient. Make sure you don't overexert them. Patient and caregiver education is super important, and I'm going to get into that in the next slide. So actually, first I want to go over the different types of MS. So there's a bunch of different types of MS, but the boards really only cares about 4 different types of MS. And just to clarify kind of what's going on with the different types of MS, the most common one is going to be the relapsing remitting type of MS. And this is the one that it's not one of the more severe forms of MS, but we do have to be careful with it, because they do have exacerbations, and we really need to make sure we're not making it worse with this patient, because it's really not going to help them at all. So let me get into the 4 different types of MS. So again, let me just go over the relapsing remitting one first. Relapsing remitting. And this is abbreviated RR. So with this one, let me draw like a little thing. So going up is the more disabled this person is, and then this is time. So for the relapsing remitting patient, they're gonna be okay. Then they're gonna have an exacerbation. Ooh. And then they're ooh. I'm gonna delete that. So they're gonna be okay. Then they're gonna have an exacerbation. Then they're gonna go down, but they're not gonna be at the same level they were before. So see how there's like a little bit worse. And then they're okay. Then they have an exacerbation. Then they're okay. So, but still see that it gets a little bit worse. And then just progressively over time, they just get a little bit worse each time. So with this patient, you really, really, really want to avoid giving them an exacerbation, because they're never going to fully recover. So that is the relapsing remitting. There's another type, it's called benign. Oop, I probably spelled benign wrong. I struggle with this. See, y'all know I'm bad at spelling. And so with this one, the patient is going to be okay. They're going to have exacerbation, and then they're going to be okay. And look, they're at the same level where they started. So they don't really progressively get worse. They just will have their exacerbations. So with their imagine that's at the same level. So with their exacerbations, they're going to get bad, but then they're going to rebound and be okay. You still don't want this person to be bad, because this bad section right here could be a couple weeks, or it could be a couple days. And that's really debilitating for the patient if they're trying to have like a full-time job or something like that. So this patient is just really big on noticing their triggers, making sure they're, with all of them, making sure they know their triggers, so then they're not getting worse. So then the next type of MS is going to be secondary progressive. And with this patient, here we go, our normal thing, they're going to start off like the relapsing remitting. They're going to get worse, get a little bit worse, get a little bit worse each time. And then they get to a point where they just continually get worse. So they start off kind of like the relapsing remitting, and then they end as like a primary progressive. So they get to a point where they're just like, you know what, we're just going to keep getting worse from this point, and there's really no more remissions anymore. So it starts off as relapsing remitting, and it gets more progressive as we go along. And then I'll show you guys that primary progressive is just a straight line. This is primary progressive. They just continually are getting worse every time. And then there is a type of MS where literally it's really bad, and that individual passes away within a few, like 2 to 3 years after diagnosis. But remembering that this one over here, I'm going to put a little star next to it. Ooh, that was a really light colored star, but this is the most common form of MS that we're going to see in individuals. I think 85% of patients have relapsing remitting MS. So that's like super common. And then, so I'll just put, this is the most common. So 1, and then the second most common one we're going to see is going to be the primary progressive, and then secondary progressive. Benign MS is random. But for the boards, understand most of the time you're going to see the relapsing remitting. So I like to draw this out to make it make sense. You guys can draw this out along with me. You can draw your own. I think that this makes it make the most sense when it comes to talking about MS. So how are we treating it? Again, as I was saying before, patient caregiver education is the most important thing. We want to avoid triggers with this patient because the triggers are going to be what causes it. And then we just want to be able to manage the symptoms as they arise. Again, this is the kind of thing where we're just trying to maintain the highest level of function with this patient that we can for as long as possible. And as I was mentioning earlier, being careful because there's a high risk of divorce and suicide in this population. So that's why we need to have what's called, and I've said it before, family-centered care. And I probably spelled that wrong, but family-centered care is a big thing with individuals who have progressive diseases such as MS and ALS and other things along those lines, especially with like children with like Duchenne muscular dystrophy and things of that nature. And so we want to make sure that we're having family-centered care in this because it's going to be more than just the patient involved. So that's why we have patient/caregiver education to make sure we're not making the patient worse, because you don't want to exacerbate their symptoms because they're having an argument over something that really didn't need to happen. So with us in the clinic, what are we doing? We're doing gait training, balance, and proprioceptive exercises. This is to decrease the patient's fall risk and also to help them be as functional as possible, because sometimes a patient can only walk like across the room and they need to sit down. We need to make sure that they're as functional as possible to help them with just existing and completing their ADLs and stuff like that. But we also want to decrease their fall risk, and especially that balance and proprioceptive exercises are going to really help decrease their fall risk. Core stability in general, I don't want to like delete that, but core stabilization in general is going to help this patient out a lot with, especially with transfers, with seated balance, with walking, ambulation, balance, proprioceptive exercises. If we have a strong core, we can do a lot. So the biggest thing, and I have it highlighted, everybody, are energy conservation techniques with this patient, because we don't want to exacerbate their symptoms. We don't want to make them worse. We don't want to hurt them. We want them to be okay. So energy conservation techniques are the holy grail when it comes to MS or anybody with a condition that requires a lot of seated rest. Assisted device training when needed. So sometimes they might, if they're having exacerbation, they might need a cane because they're off balance a little bit. They might need a rolling walker. If they're having a really bad exacerbation or they're getting more progressive, they might need a wheelchair. It really depends on the patient, and making sure that they're able to use that assisted device if they're in the event of an exacerbation, so then they can remain functional. So like maybe they're a little bit off balance, but they still can like get around their house and stuff like that. Give them a rolling walker to keep them as functional as possible. But again, we don't want this patient to fall. This patient is a fall risk. We got to be careful. Submaximal endurance program. So this word submaximal is something that the boards loves to use. So it's like its favorite thing, submaximal. That means we're not overexerting ourselves, because that goes back to, we don't want to overexert. So we use our energy conservation techniques and we take lots of breaks. This patient is okay to take breaks. This is not your patient you push and say, come on, Sally, do one more. No. This is our patient. We say, okay, let's sit down, take a little break. I love these patients because then I can get my documentation done while they do their little break, and then I'm good. And then we keep going again. Like I just quickly jot something down. They're like, okay, I'm good to go. And then we do another thing. We take a little break. Okay, I jot something else down. All right, we're good. And then by the time they leave, I'm done with my documentation and they've had a great session where they didn't overexert themselves. It's a win-win for everybody. Let this patient take lots of breaks. And here's another fun little fact: schedule everything in the morning. My MS patient that I like to treat, she likes to schedule her appointments at 7 a.m. And I'm like, you know what, girl, you do you. That works. So you want to schedule it early in the day to avoid overexertion and fatigue, because as the day goes along, they get more and more fatigued. So schedule appointments early, and then we can make sure that we get them in when it feels good for them. So keywords, understand that it's probably going to be a female. they're probably going to be white, and they're going to be young, between the ages of 20 and 35, where we have the onset of this. Now, this isn't exactly 100% when it comes to the boards, but understanding that it will most likely, the being a female is way more common, and then being white is way more common. And then you're going to see just the onset within 20 to 35. The boards might also indicate this as what's called childbearing years. So that's kind of the ideal time genetically, biologically, physically to have a baby. Do we always do that in our society? No, but here's what the boards might also say. They might say a woman who's in her childbearing years. Understand that the demyelination of the myelin sheaths in the CNS, big words here. Ooh, I don't want to delete that. CNS, that's the super important thing. And then optic neuritis is one of those things. We see optic neuritis, we have MS probably, because it's one of those things that's really only shows up with MS. I mean, there's some other really random ones, but for us being PTAs, we just got to understand, okay, we have a patient with MS, they might have some visual problems. We got to be careful because they might be like legally blind. So just being careful. And then it's going to cause a low nerve conduction velocity. So as the person progresses with their MS, their nerve velocity conduction rate goes down, and that means that things are slowing down, and that's because of the demyelination. I spell words wrong all the time, but you guys know what I mean. Anyways, so this is the things that you will see with MS. So sample question today, guys. A physical therapist assistant is treating a patient with multiple sclerosis. The patient has recently had an exacerbation that has decreased her ability to perform transfers safely or ambulate more than 10 feet without requiring seated rest. What would be the most appropriate assisted device for this patient to use in the community? 1, quad cane. 2, rolling walker. 3, loft-steering crutches. Or 4, wheelchair. So I'll give you guys a second to think about this. All right, guys, so the answer is a wheelchair, and let's just kind of break this down why. So the patient has MS, so we understand they're probably going to have some problems. They recently had an exacerbation that's going to decrease their ability to do things. So it decreased her ability to do what? Transfer safely and ambulate more than 10 feet without requiring seated rest. So that means that this patient isn't doing too much. Our also stem of the question, so what's the most appropriate assisted device for this patient to use in the community? So this is not about asking, what are we doing in her house? This means she's got to go to the grocery store, or she's got to go to the pharmacy and pick up her medication. What is she using to get around? So could we use a quad cane if it was in her house? Maybe, but this patient can't really walk more than 10 feet. So would that really be appropriate for going around the community? Remember, community ambulation is 500 feet. Remember this, guys. Community ambulation is 500 feet. So quad cane, I'm nervous with that. Rolling walker, okay, that might be okay for her house, but going 500 feet, that's a lot. And same thing with the loft-steering crutches, going 500 feet, that makes me nervous. Also transferring safely, that's also a thing that makes me super nervous with this patient, because remember, we want them to be safe. So I see a wheelchair and I'm thinking, oh, this is a beautiful, I love it. So the reason why the answer is wheelchair is because we're going out in the community. That's 500 feet. Wheelchair can get around 500 feet. And the wheelchair can also make sure she doesn't have to transfer with the wheelchair. She's going to be safe with it. She doesn't have to ambulate with the wheelchair. Well, she's technically ambulating with wheelchair, but she's not going to walk using the wheelchair. And so she can already do seated rest while in the wheelchair. So to go 500 feet in the community and not have to worry about transferring, not have to worry about walking, and making sure you can stay seated. And we don't want to exacerbate their symptoms, because remember, overexertion will cause exacerbation. So that's why the most appropriate answer for this is going to be the wheelchair, because she's able to get around, be as independent as possible. She's not going to have any more exacerbations. She's not going to be exhausted. She's not going to overexert herself. She has something to sit on. She's going to be able to get to where she needs to go. She's going to be able to go 500 feet using the wheelchair. So that's why, even though like maybe she had been in the clinic a week before walking around with a quad cane, we want to make sure this patient's able to be as independent as possible in the community. And generally for patients who have either lots of problems with ambulation, or they're only able to walk short distances or something like that, they're going to be a wheelchair user in the community. Now, granted, that might mean that at home they might not need their wheelchair, but for extended periods of time, extended distances, in order to maintain their independence, they're going to need a wheelchair to do that. And that's why not everybody in a wheelchair is paralyzed. Not everybody using a wheelchair can't use their legs. And I know you guys know this, but it's important to educate the public about this as well, that individuals that might be able to walk a couple feet would need a wheelchair to communicate, to ambulate within the community. So I hope that this was helpful, guys, in explaining a bit about multiple sclerosis, and I will see you in the next one. Take care.